Good evening. I'm psychiatrist Jay Fauver, live from Fort Wayne, Indiana. Welcome to Matters of the Mind. Now in its 26th year, Matters of the Mind is a live call-in program where you have the chance to choose the topic for discussion. So if you have any questions concerning mental health issues, you may call in the Fort Wayne area by dialing 969-2720. Or if you're calling coast to coast, you may dial toll-free at 866-969-2720. Now, on a fairly regular basis, we are broadcasting live every Monday night from our spectacular PBS Fort Wayne studios, which lie in the shadows of the Purdue Fort Wayne campus. And if you'd like to contact me with an email question that I can answer on the air, you may write me via the internet at mattersofthemind, all one word, at WFWA.org. That's mattersofthemind at WFWA.org. And I'll start tonight's program with an email I received this past week. It reads, Dear Dr. Fauver, what's the difference between panic disorder and a phobia? I worry I'm going to pass out every time I drive. It feels very real and causes great distress. Would cognitive deletion be an effective treatment? Medications haven't helped except for the benzodiazepines. There's a lot of material in that question, so let's get to work. Panic disorder is often an unprovoked sensation that emerges over the course of 5 or 10 minutes, and it gives you a fast heart rate, sweatiness, diarrhea. You feel dizzy, you feel like you're going to pass out, you feel like you're going to die or go crazy. Many people with panic attacks will have a tendency to hyperventilate, and they can have nausea. So you have all these physical symptoms emerging over the course of several minutes. Now, a phobia is where you have an unrealistic fear and thereby avoidance of something. Now, you mentioned driving. The phobia can be related to driving. Looking back, you might have had a panic attack that was unprovoked that happened to occur while you're driving. So there's a lot of different things that could be going on there. So we often going to sort out, is it a phobia related to driving itself? Now, if it's a phobia related to driving, we'd always go back to asking the why, how did it start? And you mentioned cognitive deletion. Cognitive deletion is really a variant of cognitive behavioral therapy. I prefer the term cognitive restructuring because cognitive deletion kind of infers that you're deleting or eliminating certain memories, and that's not really how the brain works. You will restructure how the brain works, and how that occurs is you can think different thoughts and have different perspectives on a bad experience that occurred in the past. So if you had a catastrophic type of perspective on a bad experience in the past, your brain physically restructures and rewires in a sense that will, basically emphasize that was a catastrophic experience, and you become more and more fearful and more worried about it. On the other hand, if you are able to understand that was an experience that, it occurred, but it's not likely to occur again, the odds are against it, you can restructure the brain so you wouldn't be so anxious and not as fearful in that case. So if the phobia is causing the panic symptoms, that could be addressed by cognitive behavioral therapy, trying to re-examine what really happened. You had mentioned benzodiazepines tend to be helpful for your symptoms. Benzodiazepines include the medications Ativan, Xanax, Valium, Klonopin. These are all medications that basically, to put it lightly, will just tranquilize the brain and make you not care so much. They will go straight to this part of the brain right here called the amygdala. It's an almond-shaped body in the front part of the temporal lobe, which is the yellow part of the brain. That's the brain looking at you right there. The amygdala will get calmed down, and amygdala is the volume control for anxiety, fear, and anger. And you can dial down the anxiety volume control very quickly with Xanax, Ativan, Valium, Klonopin, the benzodiazepines. But in doing so, two problematic factors can be seen. Number one, you might notice you have to go higher and higher to get the same effect over the course of time. But more problematic and more subtle, it will be the difficulty with processing information. The benzodiazepines will cause you to have, basically in your brain, slow internet speed. It'll slow down your ability for your brain to process more information over the course of time. So that's always been my biggest concern about the benzodiazepines. Many people will argue that they've been on them for 20, 30 years and they've been doing fine. Why should they have to come off of them at any particular time? As we get older, especially over that magic age of 65 years of age, you tend to have more difficulty with speed of processing anyway and trouble with recent recalls. So as you take benzodiazepines, that can make all those type of conditions worse. So you want to do all you can to release the brake on your brain's ability to function, especially as we get older. Now, going along with panic attacks, especially you mentioned panic attacks, fast heart rate, lightheadedness. I always want to make sure that we're not talking about some underlying medical condition that can cause those symptoms because, okay, we psychiatrists, we're really good at looking at somebody's past experiences. We're very good at identifying past traumas, for instance. Women especially are more susceptible to sexual, physical, emotional abuse, especially as children. And if you're traumatized in that way as a child, whether you're male or female, you can have a higher likelihood of having anxiety later on in life. We get that, but we shouldn't just stop there. It's so easy for a psychiatrist to just stop and say, well, you were traumatized as a child, you're going through some bad experiences now in life, that's why you're having anxiety. We can't stop there. If you're having a fast heartbeat periodically, if you're having anxiety, if you're having headaches, we have to look at the underlying medical conditions that can possibly be causing these particular symptoms, such as sleep apnea, which is where you're having difficulty with snoring or pausing in your breathing at night. That will decrease the airflow to the lungs, decrease oxygen to the brain at nighttime, and give you difficulty with symptoms such as mental fatigue, anxiety the following morning especially. Secondly, we have to make sure you don't have a condition known as POTS, postural orthostatic tachycardia syndrome. POTS is not uncommon for young women in their adolescent years, their 20s and 30s. And POTS is where you'll have this abrupt speeding up of the heart, and it'll cause you sometimes to pass out, and the blood pressure will drop substantially. And it's something we cannot overlook when somebody is having panic symptoms. Much more common with women than men, but POTS is something that is a treatable autoimmune condition. High thyroid. Let's say you're taking thyroid supplement medications and all of a sudden you've increased the dosage because your thyroid levels were seen to be a bit low. Maybe all of a sudden you're having panic attacks from that. We need to address that as well. Some people will have difficulty with panic attacks when they are just made a simple medication change. And a simple medication change is something we can often trace back and identify that maybe that was the time when you started noticing a lot of side effects, such as the panic attack symptoms. So we have to kind of review all those different things that can be factors. There's something called atrial fibrillation, where the top part of your heart starts beating really, really fast. Atrial fibrillation comes and goes, but it will give you all the symptoms of a panic attack. And finally, if you have a pulmonary embolus, a blood clot in the lungs, you'll have shortness of breath, a fast heart rate, you'll have all the symptoms of panic attack. I emphasize all those medical conditions because as psychiatrists, well, I'm a physician, I can't overlook all those different medical conditions that can be symptomatic of panic attacks. Just giving somebody Xanax isn't going to be the right approach. We need to look at those underlying factors because those underlying medical conditions can be debilitating. And it's very important we examine all of those. Thanks for your call. Let's go to our first caller, Sherry. Hello, Sherry. Welcome to Matters of the Mind. Sherry, you had asked, are there any long-term benefits using Benadryl, also known as diphenhydramine, to help with sleep? Does it cause dementia? What's the safe option to help with sleep? Sherry, Benadryl, diphenhydramine, is a medication that is an antihistamine, but it has a very strong anticholinergic effect. Now, anticholinergic effect means that it's blocking acetylcholine. When you have dementia, gradually acetylcholine is going down, down, down. Acetylcholine helps with memory and concentration. So basically, Benadryl or diphenhydramine can cause you some memory problems, number one, because it has anticholinergic effects, and number two, it does block histamine. The way it helps us sleep is by blocking histamine. It makes you sleepy. Right now, my histamine level sky high in my brain. I don't have to do any blood measurements on that. I just know it is because I'm wide awake. So if you're wide awake, your histamine level sky high. If you block histamine, it makes you sleepy and tired. So that's the whole idea behind Benadryl or diphenhydramine. It's very effective as a sleep medication, especially for younger people, but we have to remember that even middle-aged people, if they take Benadryl or diphenhydramine at nighttime, they can have difficulty, based on studies, with memory and motor coordination all the way up until noon the next day. They've done driving tests on people who took diphenhydramine at bedtime, and they found that all the way up to until noon, they had impairment with their driving skills, going around the cones and all the things they did the study. So there are other options than Benadryl for sleep, and you can start with something as simple as low-dose melatonin. Melatonin at higher doses can actually cause people to have nightmares, so we like to recommend doses of 5 to even 3 milligrams at bedtime as a means of helping helping you get to sleep. If you're also having trouble staying asleep, sometimes we'll use something that's going to work through the night. And there are a couple prescription medications that will help with sleeping throughout the night, one being gabapentin, which helps with the quality of sleep by giving you a deeper sleep overall and giving you better dream sleep. So gabapentin at low doses can be very helpful for sleep. Trazodone's been around since the 1980s for depression, but it didn't get used for depression much. Trazodone has historically been used more for sleep itself. It too can suppress the frequent awakening that many people will have. Both gabapentin and trazodone do last about 8 hours, with trazodone in about 1 out of 19 people giving them a stuffy nose and sometimes giving them a hangover effect the next day. Those are two options. A third option could be low-dose doxepin. Doxepin's been around as an antidepressant since the 1960s at doses between 50 and 150 milligrams a day, but at doses of 3 to 6 milligrams at bedtime. Tiny little doses. It too can work on suppressing histamine release in a different way than what Benadryl or diphenhydramine does, but the doxepin can actually decrease histamine firing and doesn't have as strong of an anticholinergic effect at these tiny, tiny doses of 3 to 6 milligrams at bedtime. So for many people, that can be more tolerable. But quite frankly, Sherry, for a lot of people, we simply have them go back and look at their sleep hygiene. What time are you going to bed at nighttime? What are you doing every night? When do you get up the next morning? Do you exercise in the morning? Exercising in the morning can be phenomenal for helping with sleep that night. Drinking any caffeine after about 5 or 6 p.m. for some people can keep them awake. And be very careful about eating much, if anything, toward bedtime, because you can have gastric reflux keeping you awake. And of course, I mentioned earlier the whole phenomenon of sleep apnea. If you have sleep apnea, that will be a key factor on why a lot of people are staying awake at night, because they're basically smothering, they're gasping for air, they don't realize it necessarily, and they're having a hard time going back to sleep thereafter. Sherry, thanks for your call. Let's go to our next caller. Hello, Carrie, welcome to Matters of the Mind. Carrie, you mentioned that you take Abilify, also known as aripiprazole, and you recently saw that it's also used for Tourette's. How can this be effective for multiple conditions? Basically, Carrie, Abilify is a medication that it does affect dopamine receptors, but it also affects serotonin and norepinephrine receptors in different ways. But the way that it works for Tourette's is basically a condition where you have the dopamine in the middle part of the brain called the basal ganglia. Get my brain apart here, and dopamine's a little bit too jumpy, and it causes you to have grunts and twitches, and sometimes people will use profanity and do things very impulsively, and it's thought to be a disruption of the middle part of the brain with the front part of the brain being the judgment part of the brain. But Abilify can help by blocking dopamine transmission and kind of settle down a lot of this overactivity of the middle part of the brain that's causing a lot of those symptoms of Tourette's. Abilify, as are many other medications kind of in that class, they have a lot of different receptor activities, and many times you'll hear about them being used for many, many other conditions. We not only use Abilify for psychosis, for instance, but we use it for bipolar mood stabilization. We use Abilify to augment or help an antidepressant if it's not working so well for depression. So we use these medications for lots of different reasons because they have a lot of different receptor activities. Carrie, thanks for your call. Let's go to our next email question. Our next email question reads, Dear Dr. Farver, what's the difference between an SSRI and SNRI? An SSRI is a selective serotonin reuptake inhibitor. A serotonin norepinephrine reuptake inhibitor is an SNRI. So an SSRI basically fairly selectively will increase serotonin, fluoxetine or Prozac being the first of the bunch back in 1987 that came out, and since that time, using the trade names, we have Paxil, Celexa, Lexapro, and Zoloft. So Luvox is also another SSRI that's used more for obsessive compulsive disorder, but the SSRIs are increasing serotonin. Now, here's how that works. If you increase serotonin, you'll have somewhat of an emotional dampening. In other words, you'll have a sense that your emotions aren't so out of control. You'll have less crying. You'll feel a little bit emotionally numb if you get too much of an SSRI. But you'll find that your emotions are just kind of settled down a little bit. So a selective serotonin reuptake inhibitor, by increasing serotonin, will dampen the emotions. Now, the drawback of that is sometimes it can dampen it too much, and you can have a sense of feeling emotionally numb where you don't feel happy, you don't feel sad, you just kind of feel nothing. means you're getting too much. Also, the selective serotonin reuptake inhibitors can cause you to have a little bit of difficulty with concentration, because by increasing serotonin, you can indirectly affect dopamine and to some degree norepinephrine and dampen those down. So you don't want to do that. Selective norepinephrine reuptake inhibitors include, using the trade names once again, Fetsima, Cymbalta, Effexor, and Pristiq. These are medications that are increasing serotonin, but to some degree increasing norepinephrine. Now, the old tricyclic antidepressants were serotonin norepinephrine reuptake inhibitors, such as tofranil, Doxepin, I mentioned that before, Elavil, amitriptyline. These are all medications been around for a long time. But the older medications from the 1960s and 1970s would have all this extra baggage with them, causing people to have a dry mouth, weight gain, lightheadedness, and they didn't like to take those medications. The newer medications that are more selective for serotonin and norepinephrine generally will allow a person to have a little bit better concentration, have more energy, they'll be a little sharper. They're less prone to causing a person to have difficulty with that emotional numbing, to which I referred with the SSRIs. And the serotonin norepinephrine reuptake inhibitors do a nice job in putting the brakes on pain coming up the spinal cord. So pain can be modulated by the spinal cord. If you increase both serotonin and norepinephrine, it kind of puts the brakes on the pain coming up the spinal cord. So that's why SNRI, serotonin norepinephrine reuptake inhibitors, are effective for a lot of people for pain. So we'll use them specifically for those reasons. There are subtle differences. About 1 out of 3 people respond well, based on research studies, about 1 out of 3 people respond well to an SSRI. For depression, now, for anxiety, maybe a little bit higher than that, because it can dampen down the emotional overtone to things. But an SNRI might give you a little bit better efficacy in some cases. For some people, that norepinephrine effect is uncomfortable for them because they feel kind of anxious, and you can have norepinephrine-type side effects, such as dry mouth and increased heart rate, which can be uncomfortable for some people. Thanks for your call. Let's go to the next caller. Hello, Denise. Welcome to Matters of the Mind. Denise, you want to know, is Xanax effective to help with sleep? Denise, it's effective to help with sleep for about a couple weeks. Now, you can keep taking it, but over the course of time, you'll probably notice that your sleep quality isn't as good, and you might have to take higher and higher doses. But for some people, let's say you're going through a difficult time on the job, you're having a traumatic experience. I wouldn't recommend it if you're having a post-traumatic experience where you've had a catastrophic trauma recently, because Xanax, Ativan, Klonopin, Valium, the so-called benzodiazepines, actually make PTSD symptoms worse. So depending on what kind of experiences you're going through where you need to sleep, Xanax wouldn't be the best medication for sleep. There's so many better ones out there, but people do use Xanax. It might help for a week or two, but after that, we really try to get people off of Xanax for sleep. The medications that can be used long-term, for longer term than Xanax for sleep, can be medications like Lunesta, for instance. It's a so-called Z drug. It has been studied over the course of a year, showing that it appears to be safe over the course of 1 year. We might selectively use that, but preferentially we'll more than likely use other medications that, like I mentioned earlier, gabapentin, trazodone, Doxepin. We like those kind of medications because they don't cause you to need more and more of them over the course of time, and they don't affect your concentration as much as something like Xanax. But Xanax is also known as alprazolam. It should be used short term. If you use it for a longer period of time, people typically will get kind of used to it, and it can cause you to have trouble with concentration and memory. Denise, thank you for your call. Let's go to the next caller. Hello, Mary. Welcome to Matters of the Mind. Mary, you wondered if taking additives like stevia can destroy the brain. Not that we know at this point, Mary. If they did, I would not be using those sugar substitutes myself. Stevia appears to be quite safe for a lot of people. I'm not aware of any studies showing specifically that a glucose substitute such as stevia is destroying the brain. Like with anything, we should use stevia or any sugar substitutes in moderation. As Benjamin Franklin once said, we should use everything in moderation, including moderation, or something to that effect. So in other words, moderation will be the key for pretty much anything. But stevia is something that has been around for quite some time. Just be aware of how much you're using it. There's always the debate, should we use regular sugar? Should we use sugar substitutes? What are the pros and cons of sugar substitutes? In some cases, can actually increase the craving for more sweets. It can sometimes disturb the glucose levels in your bloodstream themselves. You just have to be the best judge on that. But from a brain perspective, I'm not aware of any studies or any evidence that sugar substitutes are having harmful effects on the brain. Mary, thanks for your call. Let's go to our next email. Do we have another email? Yes, we do. And it reads, Dear Dr. Farber, what's the difference between anxiety and depression? Are there differences in the brain that create differences in these emotions? Basically, you've got 3 different networks in the brain that we use day by day. There's the default network, there's the executive network, and then there's a salient network that's in between them. The default network is what we use when we're not thinking about a whole lot. We're just being a little creative with our minds. We're daydreaming. We're not concentrating really hard on anything. We might be listening to music. We're just kind of chilling out. And the default network is a network we're using throughout the day. It's during the default network that you're kind of thinking about your past, wondering if did you offend somebody by that statement you made. You're just kind of thinking about day-to-day different things, but you're not concentrating very hard on anything. And then you've got this other extreme called the executive mode network, where you're really focusing, you're really concentrating. If you're listening to me right now, you're trying to follow what I'm saying and you're really trying to focus. You're using the front part of your brain up here when you're really trying to focus and concentrate on things. But here's the key, that salient network, the salience network is the gears in between. It's the clutch that takes you from the default network up to the executive mode network. Now, here's the problem. When somebody has depression, they get stuck in the default mode network. They get stuck there. They're ruminating about the past to an excessive degree. They're worrying about things. They can't concentrate and they're stuck. And if you remember the old automobiles that had the manual shift, where you had to clutch to go from first to second degree to third, or second gear to third gear. And if you didn't clutch properly, you couldn't go from one gear to another. That salience network that's kind of in between the default network and the executive mode network is kind of like the clutch. And if that clutch isn't working, you can't concentrate on things. So somebody's talking to you, you can't pay attention to them. You're trying to do things at work or in school, you can't concentrate, you can't focus. That's what happens when people get depressed, because they can't get into the executive mode network. They can't concentrate. They can't process their information. They get stuck in that anxious ruminative network. So we'll often hear about people getting stuck in the anxious ruminative kind of network, and they can't get out of that. And for those people, yeah, to some degree, they can get benefit from the serotonin medications to calm some of that down. But more often than not, we find that people have difficulty kicking in to the executive mode network, where they're really trying to concentrate and focus, and they can't do that because of depression itself. So anxiety will often keep you stuck in this default mode network, whereas depression will prevent you from going into the executive network where you can concentrate. It's often a cascade. Many people will have anxiety and they'll worry and they'll ruminate, and because of that, they'll have trouble with sleep. Because they're having trouble with sleep, well, that will affect your ability to concentrate and focus, because sleep refreshes the front part of the brain that you use for decision making and concentrating and decreasing distractibility. And if you can't sleep, that's all impaired, and that keeps you out of the executive mode network. So we're often trying to sort out where somebody might be in terms of struggling with these different networks and try to address our medications accordingly. Again, if somebody's really ruminative and they're stuck in the ruminative network, we might give them something that's going to affect serotonin more. If they're having more trouble with concentration or focus, we might give them something that's going to affect more dopamine or norepinephrine. And we're trying to sort out to what degree people are having trouble with those different networks. Thanks for your call. Let's go to our last caller. Hello, Richard. Welcome to Matters of Mind. Richard, you had an event occur on the highway, gave you a lot of anxiety. You want to know how you can get more comfortable driving on the highway. You take hydroxyzine occasionally, and you want to know if you could take this more regularly, will it help? Hydroxyzine is somewhat similar but different than diphenhydramine or Benadryl, to which I referred earlier. Benadryl or diphenhydramine will have more of an anticholinergic effect. Hydroxyzine is better. Hydroxyzine is an antihistamine, but keep in mind, as an antihistamine, it's basically blocking histamine, which makes you less alert and less awake. Not necessarily a good means of treating an anxiety condition. I know it's very commonly used because it's very safe. It's not addicting. It's not something that's controlled by any means. So it's much safer than a benzodiazepine, but there are other things that could be used other than hydroxyzine, gabapentin, pregabalin being two options. Buspirone, often used for worry for a lot of people. So hydroxyzine, my only concern there would be, is it making you tired? Is it making you sleepy? Now, what can you do to get back out on the highway if you had an event occur out there? Try to get out there in small doses. For instance, I'll often advise people to go from one exit to another just to get back on the highway in the section that makes them anxious. Many times people will say it's an interstate, it's a state road, it's a particular area that made them anxious because that's where the event occurred. What you want to do, Richard, is restructure the wiring of your brain to get your brain convinced that, yep, you can have bad things happen on the highway, but it's not necessarily going to happen every time. Your brain right now is structured in such a way that it's telling you every time you get out there, something bad's going to happen. If you can get out there more and more, you'll realize that that's not going to be the case. Richard, thanks for your call. Unfortunately, I'm out of time for this evening. If you have any questions that I can answer on the air, you may write me via the internet at Matters of the Mind, all one word, at WFWA.org. And remember that our episodes can be seen now on YouTube. I'm psychiatrist Jay Fauvre, and you've been watching PBS Fort Wayne Matters of the Mind with Dr. Jay Fauvre. Thanks for watching. Have a good evening. Good night.